Can I just check if you can see my screen?
Yeah, you can see your
Yes.
screen, Marianne.
Yeah, I'll
And
put
I
it.
would like to take this opportunity to welcome all the mentors to the fifth SSNC webinar. And today is a very important topic, a topic that all of us know, but the big challenge is implementation, that is on breastfeeding and lactation support. And to take us through this webinar, we invite Marianne to
Yeah.
take us through this breastfeeding and lactation support. And we'll be discussing further on later during our mentorship workshops and meetings. Over to you, Marianne.
Thank you, Suman. Good afternoon, good morning to every one of you. The way we will do this particular seminar is going to be very interactive or using basically case scenarios. We all do know mother's own milk is the best, irrespective of whether it is a term baby or whether it's a preterm baby, a sick baby, or a well baby. And that's why this session only on breastfeeding, breast milk feeding for babies. What we will be covering today is one, in terms of review the recent recommendations on breastfeeding and its significance on small and sick newborn care. And the second is to discuss and demonstrate how health workers can support mothers with small and sick newborns to ensure early breastfeeding initiation, breastfeeding maintenance before and after discharge, as well as in terms of alternative feeding methods. So with regards to initiation of breastfeeding, what are the recommendations by WHO is one is immediate and uninterrupted skin-to-skin contact from birth. The second is initiation of breastfeeding within the first hour of life. Support mothers soon after birth to initiate as well as to maintain exclusive breastfeeding. And exclusive breastfeeding must be the norm unless clinically indicated. And there are references which I've put in this particular slide. I would recommend that you all please go through these guidelines and this Cochrane review with regards to initiation of breastfeeding, especially with regards to skin-to-skin contact. Reasons for these recommendations is one, we do know it is a mother's right as well as a baby's right to be breastfed. Babies need protection and security to breathe, warmth, and feeding is an essential component of their need from birth onwards. Mothers also need to feed their babies to feel secure and to care for their baby because it has both health as well as physical health as well as mental benefits for the mother. We know it reduces mortality, and when we say it reduces mortality, the risk of dying in the first 28 days of life is 33% higher if the baby was fed 2 to 23 hours after birth, and more than twice this amount for those who were initiated 1 day later after birth, compared to newborns who were initiated on breastfeeding less than 1 hour. It reduces morbidity, all of us are aware of that, and improved neurodevelopment or brain development. Plus, there are several other benefits for both the mother as well as the baby. We're not going through that because I presume all of us do know this. So, exclusive breastfeeding maintenance. How do I do this to promote early and exclusive breastfeeding in health facilities as well as at home? We are specifying this basically because though we are focusing on preterm births, we do know a lot of preterm births also, mothers and babies go home within the first 24 hours or even within 5 to 6 hours after birth in the facilities that we are dealing with in this project. So it is important for us to understand the first few hours and days of a newborn's life are a critical window for establishing lactation and providing mothers with support they need to breastfeed. So when we speak about that, is one is to facilitate an early start, and the best way is through might be skin-to-skin contact soon after birth for at least an hour, support expressing or expression of breast milk if babies can't feed, and counsel mothers on various aspects. And these are three aspects that we will be covering with regards to exclusive breastfeeding maintenance. Okay. Recommendations and reasons for cup feeding. This is another recommendation. Low birth weight babies who need to be fed by an alternative oral feeding method should be fed by cup or a palada that we have in Southeast Asia, which is a cup with a beak or a spoon. Benefits of cup feeding, all of us do know. It improves breastfeeding rates, it reduces desaturation and apneic spells. It also reduces the risk of severe infection because it's much more easier to clean these cups, affordable and accessible. And mothers can easily learn how to cup feed. Problems with regards to bottle feeding, we definitely know it is definitely more expensive, difficult to clean. There's increased risk of infections, gastroenteritis, and it also allows overfeeding. There's also a risk for aspiration with immature suck, swallow, and breathing coordination in especially the small babies. These are the various sources. We will be sharing this with you so you will be able to get all these resources with regards to breastfeeding, what we are recommending in this particular project. What are the skills related to breastfeeding? The first one is to ensure skin to skin support. I have provided a link for the Global Health Media video on skin to skin support. Kindly go through that when you have time. Breast, we do know why skin to skin support skin to skin contact is recommended is basically because we know it will benefit the mother as well as that of the baby. The breast secretions, especially from that of the Montgomery glands and the amniotic fluid, smell similar. So that facilitates the baby to move towards that of the breast. And if the baby is kept in skin to skin, at least for an hour after birth, you will find babies initiating breast milk feeding as early as possible. Watch for feeding cues. There are specific cues that small babies and even babies, term babies, will really present with if they want to feed. And so we will run through that. Support and communicate how lactation can be established. Colostrum can be expressed and given, can be expressed and given to babies even if the baby cannot feed directly, and know the different types of breast milk. These are some steps that we need to keep in mind to support mothers. So recognizing and responding to feeding cues, both mothers as well as healthcare providers, especially healthcare providers in probably the SNCU, to be able to recognize, is this baby ready to feed? They might open their mouth, turn their head, if they are with the mother to find the breast. They are wakeful and restless. They might make small noises. Salivation can increase. They have hand to mouth movements, and they also, you'll find them sucking their fingers, sucking their fists, licking and smacking of lips is also typical of the cues that small babies or even any baby would present with. With regards to colostrum, colostrum is referred to as liquid gold or the first immunization. And why is it liquid gold? Basically because it is yellow in color, and it's that yellowishness comes from vitamin A content. We know it is high in maternally derived immune factors, probiotics, human milk, oligosaccharides, which serve as food for or prebiotics and decoys of pathogenic bacteria. It also has bioactive proteins. It safeguards the mucosal barrier. Okay, so it gives a protective layer full of maternally derived immune factors. It promotes a favorable microbiome, and it educates the immune response of the newborn itself to be able to respond to infections. So that's the benefit of ensuring that colostrum gets to any preterm baby as well as a term baby, whether sick or not. Today, people recommend, and what is recommended is also might be giving a mouthwash or just swabbing the oral cavity with colostrum could definitely help these babies. Support mothers. Support the mother either during the antenatal period. It is ideal in the labor room to initiate breastfeeding and early postnatal period. And I've got an acronym over here, GALPAC, that is greet the mother always, ask them questions, what do they know, listen to them, praise them for what they are doing, as if they are doing good, advise them, and then confirm whether they have understood what you have spoken to them. Types. So what we will support mothers on for them to understand what are the types of breast milk and their composition, because many of them might have doubts whether milk is enough, whether milk what they are producing is sufficient for the baby, etc. The volume a newborn can take. All preterm and small babies should receive mother's own milk. Prolactin milk secretion reflex, the oxytocin milk ejection reflex, and support the feeding reflexes of the baby. These are ways in which you could educate mothers to and support them to establish and continue exclusive breastfeeding. So the types of breast milk and their composition, all of us are aware. Colostrum, which is normally secreted from day 0 to might be day 22 up to day 3, where the fat composition is very high. The protein composition is also much higher compared to the lactose. As we go forward from day 3 onwards, fore milk. In fore milk, you will see that the lactose component, as well as in hind milk, the lactose component is stable. But what is different is the fat composition. Fat composition in hind milk tends to be higher. So if we find a baby is not putting on weight, I would definitely want to check whether that baby is only receiving fore milk or whether the mother is emptying her breast when she is actually feeding the baby, so that the baby gets the hind milk and is put on. So even in terms of expression of breast milk, it is important that we ensure that the breast is emptied. Okay, so that is so that the hind milk is given to the baby. The other difference that we definitely need to keep in mind is with regards to the composition of full term versus preterm. And the main thing that you are definitely aware of is preterm babies, more protein, as well as more sodium chloride and iron. And that is why it's important that a preterm mother feeds her own baby rather than getting donor milk, so that it is for that particular baby itself. It will definitely benefit. So we've looked at colostrum, we've looked at fore milk, and we've looked at hind milk. The volume of a newborn stomach. Important for us to understand might be how much can a newborn take in the first day, in 3 days, and 1 week later, 1 month later. Can I request you to mute yourselves? Those of you who are talking, please. So colostrum, normally the colostrum phase occurs up till the 7th day of life. Usually when colostrum starts being secreted from 7th month of pregnancy, sometimes up to 2 ml might come out, and by the 7th day up to 60 ml might come out per feed. The lactose secretion, lactose quantity and the protein is much higher in colostrum, and fat is 2 grams per 100 ml. Transition milk from the 7th day to the 15th day, and the mother can produce up to 750 ml per day. And mature milk from the 15th day onwards, where she might be able to produce around 1000 ml per day. All preterm babies, as I've already explained to you, the composition of milk is different. So mother's own milk is baby specific, and it's preferable that the mothers feed their own babies, or mother's express milk is given to the preterm baby. You're aware of the milk secretion reflex, prolactin, but to be aware of what are the enhancing factors. Emptying the breast. So if a mother is not breastfeeding because the baby is sick, or it's not recommended to breastfeed the baby, she should be emptying her breast. She should be expressing breast milk. Sucking is another way. So probably non-nutritive sucking is something that we can allow. Night feeds if she is feeding the baby, or she continues to express the breast milk. Bottle feeding, incorrect position, and painful breast are hindering factors for the prolactin milk secretion reflex. And usually this works after a feed to produce the next feed. Oxytocin milk ejection reflex, the enhancing factors, loving thoughts of the baby, which means the baby needs to be with the mother. Important. The sound of the baby, the sight of the baby, so bedding in or rooming in or zero separation are concepts that we need to keep in mind, and the confidence of the baby. Hindering factors are worry, stress, pain, and doubt. And you know the oxytocin milk ejection reflex works before or during the feed to make the milk flow. These are some of the signs of oxytocin reflex: tingling sensation, milk flowing from the breast when the mother thinks of the baby. You'll find her clothes getting wet, milk dripping from the other breast, milk flowing from the breast in fine streams sometimes, pain because of uterine contractions, sometimes with a rush of blood during feeds in the first week. This is typical in the first week. Slow, deep sucks and swallowing by the baby, showing that the breast milk is flowing into the mouth. And tell the mother about when to know if baby has had enough and the risks of hypoglycemia as well. Support the feeding reflexes of the baby. Important, the mother learns to position the baby so that the sucking and the swallowing are coordinated, as seen in this picture. The rooting reflex, the baby opens the mouth, baby turns towards the moment anything touches the cheek or touches the baby turns towards that particular aspect. So that is something that the baby can learn, and the sucking reflex. So baby learns to take the breast, but if the position is not correct, how the mother holds the baby, it can affect the baby. Actually, it can affect the way we are supporting the feeding reflexes of the baby. So let's look at this case scenario. At 34 plus 2 weeks, male baby around 2,100 grams was delivered vaginally and cried at birth. The baby was put on skin to skin at birth for 5 minutes and then taken for routine care. What are the barriers here for initiation breastfeeding? Can we see, can you all might be write something in the chat if you want to, if you can write, and can I ask either Suman or Flavia to read what is in the chat because I may not be able to see it. What are the barriers here for initiation of breastfeeding? Just look at that first question. Any responses?
Okay, I'm looking into the chat and
But none
we
yet.
don't have
No
yet.
responses yet.
Okay.
Separation.
Okay, we have a first one.
Yes.
Sarah Ango has said separation is a barrier.
Yeah. Thank you.
Difficult to express for sick mother. Interrupted skin-to-skin contact.
Yeah.
We're
Perfect.
getting lots of answers. Yeah, separation.
Separation. Perfect. So you'll find, yes, the barrier is definitely SSC, and skin to skin contact is recommended at least for at least 1 hour after birth. If it can be continued for longer time, there's nothing like it for a preterm baby or a low birth weight baby. Probably no birth companion to support the mother, because sometimes a healthcare provider might be busy looking after the mother and they may not be anybody to support the mother. So if there is a relative, or if that's a policy that we definitely would need to look at. Is there a birth companion? And the baby can become hypothermic, hypoglycemic, sorry, and because of this, infection prone. So the support that is necessary for this baby is definitely skin to skin support, and also to observe a feeding, like we've seen in this picture, where the nurse or the birth companion, whoever it is actually supporting this baby to feed, to breastfeed while the mother is even lying on her back. This is another case scenario. Yes, she delivered a 34-weeker, 1.950 grams baby who cried at birth. This is her first baby and she was not sure how to feed her baby. How can you help her? We will go through these aspects: the correct attachment, correct position, different feeding positions, and zero separation. Many of you are experienced neonatologists or pediatricians over here in this group, but it's important for us to reinforce that these are crucial for not only initiation of breast milk, but also for actually maintenance of breastfeeding. So correct position attachment, which is the correct attachment in this picture. Can we have your responses, either one or two, in the chat, please? Any responses? If you look at picture 1 and picture 2, which depicts correct attachment
Yes,
of the...
there are quite a few responses. One,
Perfect.
many responses, one.
Yes, thank you. So
Amari,
I've
yeah.
replaced that with another picture, with an actual picture of a baby. And if you look at these features, definitely the mouth is wide open, more areolar, seen above the lip than below, and mostly inside the mouth of the baby. The lower lip is everted. You can see that the lower lip is everted, and preterm babies might have that difficulty. It doesn't get everted, it gets inverted. Chin touching the breast. This is another aspect that you can definitely see it if the baby is in correct attachment. Signs of correct position. If you look at this picture itself, the baby's body is well supported. The baby's head, neck, and body are kept in the same plane or in a straight line. The entire body of the baby faces that of the mother so that the baby can latch on to the breast well, and baby's abdomen touches the mother's abdomen. These are ways in which you can know the correct position of the baby. So there might be some SSNC leads over here. This is something that you should take a cue with regards to when you observe, or even might be as mentors, when you'll observe breastfeeding episodes in the SNCU. Different positions that the mother can have. Might be a laid back nursing position, as the previous picture that I also showed you. Sorry. And then cross cradle hold, football hold, the cradle hold, and sideline positions. And laid back position, cross cradle hold, and football hold. These are three positions which are normally recommended, especially for small babies or low birth weight babies, because mothers are able to support their babies well, and the baby is also able to latch on to the breast well. Rooming in, zero separation, definitely a way in which to see that the mother and the baby are day and night together. Mother can respond to baby and to the feeding cues. Baby gains weight. Breastfeeding continues longer, and it helps in the bonding and breastfeeding. Very, very essential before the mother leaves the hospital to see that you observe at least one feeding episode. So as mentors, to be able to tell the staff, at least observe one feeding episode to know that the mother knows how to breastfeed her baby. That is something so that you know that the mother is confident to breastfeed as well. Now let's look at feeding small babies. This is a case scenario, a little long. A 30-week primigravida woman delivers a male baby who did not cry immediately after birth. The baby was dried, baby's umbilical cord was cut immediately, and baby was resuscitated with bag and mask for 2 minutes. Baby's heart rate is 120, respiratory rate 55 per minute, and good color with good muscle tone. Baby was transferred to the neonatal unit of your health facility. How would you ensure this baby is fed with mother's own milk as early as possible if there is no clinical indication for not breastfeeding or not giving breast milk feeds? We will review this part of the question now. If you look at this, this is the guidance for initial method of feeding, especially the small preterm babies. The first one is to allow to latch and assess the newborn's effectiveness at the breast. Especially here in this case, might be the baby is in the SNCU. So the newborn, if the newborn is able to latch, suck and swallow well, And this is usually after 34 weeks. The scenario is this baby is less than 34 weeks. So, but if the baby is more than 34 weeks but still preterm, initiate breastfeeding. The newborn is able to suck effectively and demonstrate audible swallowing. Encourage the mother to continue breastfeeding. If the newborn is able to latch but not unable to suck effectively, no audible swallowing, usually gestational age is around 32 to 34 weeks, breastfeeding plus express breast milk by spoon or cup. And observe whether the newborn is accepting well without spilling or coughing and able to accept adequate amount of milk. If yes, continue both spoon, cup feeding as well as direct breastfeeding. But if no, observe whether there's any vomiting or abdominal distension occurs. If the baby is less than 32 weeks, which was the scenario in this particular case, start feeds by orogastric or nasogastric feed and non-nutritive sucking for babies if the baby is more than 28 weeks. Gestational age between 29 and 31 weeks, what do? You observe whether vomiting, abdominal distension occurs and continue orogastric feeds. And then as the baby becomes older in gestational age, you can proceed to spoon and cup feeding. If the baby is less than 28 weeks, then minimal enteral or trophic feeds with intravenous fluids is what is recommended. So this is the guidance with regards to feeding such babies. So in that case, there are skills that the healthcare provider or the health worker will have to help the mother to learn. One is successful expression of breast milk by stimulating the oxytocin reflex, providing a quiet environment, privacy, helping the mother hold the baby or see the baby itself so that the baby mother can stimulate the oxytocin reflex, skin to skin contact, warm soothing drink, warm massage or breast uh, massage the breast, then warm shower, rub the back parallel. These are pictures, okay? Parallel to the shoulder blades, neck and downwards, and express every 2 hourly. These are some things that can be taught to the mother, especially for that of preterm and small babies. Support the mother's expression of breast milk, and these are steps that we will definitely learn at a greater extent, like washing the hands thoroughly. This is important, both of the healthcare provider as well as that of the mother. Hold a clean white neck container under the nipple. Place the thumb and the first finger behind the nipple. I will give you links for this so that you'll be able to see the videos. Compress the breast between the thumb and the finger and repeat this all around the breast and the nipple. And this should be done at least 5 to 6 times, sometimes up to 8 times for at least 20 to 30 minutes so that you get the hind milk also expressed. How to store expressed breast milk? Storage, okay, if it is might be at room temperature between 60 to 85 degrees or 16 to 29 degrees up to 4 hours. And if it was thawed, previously frozen, up to 1 to 2 hours. If the breast milk is stored in a refrigerator, freshly expressed and pumped breast milk can be kept up to 4 days. And thawed, previously frozen, up to 1 day. But if freshly expressed breast milk is kept in the freezer, you can keep it up to 6 months. Sometimes up to 12 months is acceptable. But never refreeze human milk after it has been thawed. Leftover from a feeding, it should be used within 2 hours after the baby is finished feeding. Show the mother how to feed with a cup. Okay, this is important. There are different cups that can be used. There are some pictures that are given over here. I've not shown you a picture of a palada, but a palada will also be a metal one, which has a beak. Containers should hold at least around 50 to 90 ml. Measure the amount that needs to be given to the baby. The edge of the cup and spoon should be rounded and smooth. A cup with a lid is useful because it can be stored. The breast milk can be stored safely, and do not pour the milk in the mother's into the baby's mouth. It can be very dangerous. The other aspect is placing a nasogastric tube I'm running through this because they're just simple steps that can be done. But as healthcare providers, they should know how to measure the tube from the tip of the nose to the tip of the earlobe, and then down to the mid portion from the cephisternum to the umbilicus. Okay, so that's where you would place it. It's always best to mark that place, mark the length of the tube that needs to be inserted before we insert into the baby. It could be either nasogastric or it could be orogastric based upon the policy of the institution. Steps for safe nasogastric or orogastric feeding. Calculate when you know that the tube is in place, calculate the volume of express breast milk that needs to be given. Which newborns should not be breastfed? Those with bowel obstruction, necrotizing enterocolitis, intolerance, unconscious or frequent convulsions. How do you feed the baby with express breast milk? Fix a 20 ml sterile syringe to the end of the tube and pour express breast milk into the syringe and hold the tube above the baby's head. Document it and follow the national guidelines every 3 to 7 days to change the tube. These are points to keep in mind. This is it might take a little time. Is there time, Flavia? Can you just let me know? There's half an hour.
Yes, we are 37. I think you can go for it. Yeah.
I can show this to them.
Go ahead.
I think so. Yeah.
Yeah. Can you see the video?
Yes, we can.
Yes.
You can just play it. Yeah.
Oh, you might want to stop sharing and start sharing with sound. We cannot hear the sound.
Okay.
You can just
2 or
stop
3
sharing.
hours, as often as
Oh, now
any
it's good.
baby.
We can hear now.
Involve the mother in feeding her baby. Caring for her baby helps build the bond of love. This video will show how to feed the baby with a gastric tube. First, check the chart to determine the amount of milk for each feed. Our 3-day-old baby weighs 1.4 kilos. Today, he needs 18 milliliters of breast milk every 3 hours. Have the mother wash her hands and express her milk into a clean
Marion, we cannot hear anymore. I think you're muted.
syringe
Can you
to
hear
draw
now?
it up.
Yes.
Give her positive encouragement as she learns to feed her baby in this new way. Always check the location of the mark on the tube before each feed. If it has moved, adjust it or replace the tube and recheck the placement. Then connect the syringe. Remove the plunger and hold the barrel just above the baby. If the milk is not going in, barely insert the plunger and push down slightly, then remove. The milk will move slowly into the baby's stomach. Each feeding should take about 10 to 15 minutes. When finished, remove the syringe and cap the tube. A common mistake is pushing the plunger to speed up the feeding. This can be dangerous. The baby can vomit and possibly breathe milk into the lungs. Wash the feeding syringe and cup with soap and water for the next use. Encourage the mother to put the baby to her breast before each feed. This helps babies more quickly develop their feeding skills and improves the mother's milk production. When the baby can effectively breastfeed, remove the tube. Replace the tube every 3 days or sooner if it becomes blocked or pulled out of place. Remember, check the chart daily.
Sorry, just
Marianne, it stopped.
yeah. I have stopped the video. I will continue with the, just let me just share my slide again. Can you see my slide now?
Not yet, not yet.
Not yet?
No.
Sorry.
Still not.
Yeah, it's coming. It's coming.
Yeah.
I see it
Now
now.
we can
Yeah.
see.
It's gone back. Okay, so we went through placing a nasogastric tube and also how to ensure that a baby who's getting tube feeds is safe, is given the feed safely. Flavia, would you want to go through this, the job aid?
Yes. So this is the job aid for feeding, for mother's own milk feeding for ACSIR. So basically everything that Marian has gone through is there. It's just, this is going to be a tool that is going to be presented in all the facilities, the intervention facilities, the core facilities, and also the peripheral facilities. So basically start with mother own milk explication, who, so the best option for every baby, regardless gestational age and weight. Mother's own milk adapts to the baby weight. All babies should receive, so when all babies should receive any available amount of mother's own milk as soon as possible, ideally in the first hours of life. How? So tiny amounts, less than 1 milliliter, can be given orally, even to thick and small babies. As production increases, switch to indicated method below. And then on the other side, you have even sick babies may be initiated to trophic mother or milk feeds. Only contraindications would be gastrointestinal malformation, necrotizing enterocolitis, and shock, which Maren has gone through already. So basically, the indication here is to start mother or milks to all babies that are not in this group. Going down, we have the guidance from WHO. So this is the guidance from the KMC guide that Marian already went through the whole flow chart. So this can be used as a tool in the field. On the right side, you have some information on counseling. Counseling is essential prior to breastfeeding. Always explain to mother why, how, and when to breastfeed. And then we have some more information on every day. So this is to be done every day, even if the baby cannot suck strongly after birth, non-nutritive sucking in the breast. So we are calling NNS, must be offered during tube feeding. So even those babies that you saw that are tube feeding because they cannot suckle, they are also entitled for non-nutritive sucking. And non-nutritive sucking contact with the breast, with sucking in the babies that are unable to extract milk or coordinate suck, swallow, and non-nutritive sucking can also be offered during painful procedures. So basically, we can do non-nutritive sucking during painful procedures to reduce pain. We can do non-nutritive sucking contact with the breast while the baby is having the feeds on the energy tube. And this ideally we can do even every 3 hours, basically, depending on the condition of the baby and depending on the facility. But it's something that can be done to any baby that is not in that severely sick group. On the bottom, we have some information on hypoglycemia. We are going to through hypoglycemia in a whole section, but it's just some information that for all preterm babies, check blood glucose, pre-feeds for at least 3 normal checks. So it's a little bit cut there, but it's just because of this slide. This is not cut in the whole job aid thing. And we have the whole protocol of hypoglycemia in the other, the seminary that is dedicated to that. So in this one, on the other side of the job aid, so it's a 2-page job aid, we have information on bilious aspirates. So bilious aspirates are always abnormal, but a well preterm may have observed bilious aspirates without withholding feeds. If the baby is unwell, of course, stop feedings and investigate infection and obstruction. Now, if you have a term baby with bilious aspirates, something completely different. So you have to think about volvulus malrotation. So that definitely have to stop feedings. This is more to say that there is a difference between term and preterm. And then we have mothers should continue expressing at least 8 times a day when baby is very sick, receiving lower amounts than expressed or new by mouth. So this is important because sometimes the mothers, they will stop expressing when the baby is not being fed. And this is basically can completely stop lactation. This is very important to stimulate the breast, even when the mothers are not feeding all the milk that they are expressing, or even if the baby is new by mouth. On the other side, we have some more important information. Always check the positioning of the tube before feeding that Mara also showed. Tube feeding speed is low gravitational. Do not push milk inside the baby's tube. And then on the bottom of it, we have some do's and don'ts, transitioning from tube feeds to active feeding. So this will happen around 33 to 34 weeks. So remembering that graph. So do's. So check baby's cues for feeding. If baby is waking up and showing signs of readiness for feeding. Also, if baby is showing signs of readiness, offer active feed, breast milk ideally, or spoon cup before initiating tube feed. So start with active feeding and then go for tube feeds, always respecting the baby. If baby is less than 33 weeks or not coordinating feeds yet, non-nutritive sucks can and must be done whenever the baby is awake, and teach the mother about feeding, expressing breast milk, and breastfeeding. And on the don't side, on the right, is don't wake up the baby. Sleep is important for development. Use the tube. Wait for the next feed to try active feed. So this is for those babies, 33 to 34 weeks, when they might be getting ready. If they're sleeping, just let them sleep. Feed through the tube. On next feed, if the baby's awake, showing signs, you can try an active feed. Don't prolong feed trials more than 15 minutes. So the baby might get tired and this might make you go backwards. So don't force too much. Basically, that's the idea. Don't rush active feeding progression. Each baby is different and each day is different. So follow the baby cues. And it's also important to tell the mother that each baby is different. They tend to compare themselves to the other ones, the other babies. Don't forget about non-nutritive sucking. Again, this is a foundation for establishing good active feeds and can also be used as a pain relief. And all of these, of course, can be done with KMC. Okay, I will go back, switch back to you, Marion.
Thank you. Thank you, Flavia. Now, how do you transition from alternative feeding methods to direct breastfeeding? Basically, this is basically as what Flavia has just mentioned. Non-nutritive sucking can be done during tube feeding itself so as to facilitate and help this baby get that coordinate, at least learn. Of course, it is a rhythmic sucking behavior that you are aware of, not associated with consumption of milk and typically observed in an empty breast. And it is known to also reduce hospital stay by 4.5 days and time of to transition from gavage to full oral feeding is reduced by 5.5 days. So it is essential that this is a practice that health workers are encouraged to do in the facility so that the baby can progress from tube feeding to direct breastfeeding. Then I just... Now let's look at, as mentors, when you go into a facility itself, it is important to identify facilitators and barriers with health workers with regards to initiation of breastfeeding as well as maintenance of exclusive breastfeeding. So look at systems as well as look at the processes that could be contributing to either as facilitators or early initiation of breastfeeding and maintenance of exclusive breastfeeding. So what are some facilitators from the systems point of view as well as from as processes for maintenance of exclusive breastfeeding? Do we have time? Otherwise, I will go through it. But these are some things that we need to keep in mind. Check these facilitating as well as barrier practices in your own setting as well as in the setting of the co-facilities. One is in terms of systems, policies, family participatory care, open visitation, birth companion, especially in the open visitation in the SNCU, birth companion in the labor room, separation of mother-baby soon after birth. That could be a barrier. But zero separation is a facilitating factor. Health workers training on lactation and lactation support, availability of IEC, and space and privacy for feeding. So these could, if they are not there, it could be a barrier. If they are there, they could be facilitating factors. And facilitating processes, health workers practice skin-to-skin contact, expression of breast milk or colostrum. They are aware of how to do it and to how to support mothers. KMC, very important to continue, especially for preterm babies. Family participatory care, support and teaching of mothers in terms of how to position and what is good attachment, and lactation rounds at least once a day to go and see these babies so that we know and ensure that the babies are actually getting adequate amount of milk. Hindering processes is lack of support for the mother. Withholding fluids during labor and early postnatal period can definitely be a hindering factor for mothers to breastfeed. Pain medication during labor and interventions which are not recommended, which could be cause discomfort for the mother, could be a barrier for the mother to initiate breastfeeding. Separation of the mother and baby, swaddling, very tight limbs, etc., can prevent the baby from having its normal movements, etc., and can definitely can be a hindering factor for feeding. So these are some points that we need to keep in mind with regards to it. I will not be covering difficulties in breastfeeding, but we will be going through it at some time during your own sessions with staff when you go to the facility. And this is all with regards to my the presentation on breastfeeding, breast milk feeding, as well as supporting mothers for breastfeeding. Over to you, Suman. If there are any questions, any other points, I will stop sharing my slide.
Yeah, thank you, Marianne, for a very clear and detailed sharing on breastfeeding and the challenges and how to overcome it. I see one question by Dr. Aman from Dhaka of how non-nutritive suckling can be done. We can't hear you anymore. You're muted.
Okay. Non-nutritive suckling can be done easily. One thing is definitely to support the mother in positioning the baby. It is important that the mother's breast is empty. That is one thing that can be done. It can either be done on an empty breast of the mother, or it could sometimes, some people will also recommend might be the thumb, but it should be a clean thumb, a clean finger, definitely. Some people use a glove, but the glove will not give you the best kind of will not give the baby the best kind of experience. So keep this, and at least might be 6 to 8 times in a day, if possible. If the baby is not too sick, you can do this for the baby. It basically strengthens the baby's capacity to suck and also to swallow before starting breastfeeding. Suman, would you want to add to it?
Thanks, Maria. Not much, but just to say that even the smallest and the sickest baby should be given an opportunity to suckle on the mother's breast. And initially, when the baby is sick and unable to directly breastfeed, it would be on an empty breast, which would be non-nutritive suckling. And if we want to do it as even more detailed, then the little finger would be used. But as Marianne said, it should be clean, hand washed, and you don't use a sanitizer. This is one time that you don't use a sanitizer before we use you do the non-nutritive sucking with a little finger. And usually, in at least in our units, I invite the mothers to do non-nutritive sucking with a little finger, and not the health personnel, because it may not be the best. And when we use gloves, like Marianne said, it doesn't give us the best feeling for the baby. So encourage the mother to do it on her breast or on her little finger. In the West, in the developed countries, many of them use pacifiers, and they have used, but we do not recommend it. At least in my own unit, we don't use pacifiers at all, because we are worried about infection. But otherwise, pacifiers has also been a mode of doing NNS. So I don't see any questions, but I think all the mentors are encouraged to maybe unmute, raise your hand, and we'll invite you to unmute and ask your questions. And also maybe to share your experience. See, breastfeeding is something that all of us do it as an intervention, and also have our own struggles and our own innovations to overcome those barriers. So it would be good if you would like to share anything or even ask any questions. Over to you all.
You can see there are two hands,
Yes.
Suman. There is Tegene and
Yeah, let's call upon
Dr.
them. Yeah. Tegene. Dr. Tegene,
Hello.
over to you.
Yes. Okay. Thank you very much, Marianne, for the excellent presentation. I have two questions. And so overall, regarding the feeding of these preterm small babies, yes, maternal breast milk is the ideal feed. Therefore, overall, this feeding or nutrition is crucial for both nurturing and developmentally supporting care. So in calculating the volume of feed on daily basis, especially for babies that started on trophic feeding, which weight we are to use, because there are physiological weight loss, especially in the first 7 to 10 days, and then they start to regain their weight, catch up growth is there. So what is your comment on regarding the use of this weight to calculate the volume on daily basis? The second question is, again, there are in some scenarios, there are babies who started on trophic feeding, and the volume is calculated accordingly. And finally, with the maximum volume we calculated, baby may not gain weight appropriately, and that means there could be a failure to gain weight. So how can we fill this gap, especially regarding the nutritional gap filling with fortification? What is your comment on that line? Thank you very much.
Flavia, can you just answer that? Is Flavia there? Suman?
Yeah. Marianne, Dr. Tegene, I got your second question, which I think is about fortification. And oh, sorry,
Birth weight.
it's about
Birth weight.
fortification as far as the WHO guidelines is concerned. The fortification is a conditional recommendation, and it is mainly for babies who are less than 32 weeks and who may not be growing well. It improves the immediate growth of the baby, but as far as long-term outcomes are concerned, we do not have any great data to show that it improves neurodevelopment or has long-term benefits. So we all do use fortifiers, human milk fortifiers. Most of them are cow milk based, and especially for babies who are very small and who are not growing well. It adds a lot of cost, and therefore in our national guidelines it is for even babies less than 1800 grams, but in our unit routinely for babies less than 1200 grams we do use human milk fortifiers. But we use it till around 2 kgs, and once a baby is predominantly on direct breastfeeding, then it's difficult to express the milk and give HMF. I did not get your first question, so can you please repeat that?
How to calculate the volume of feed? On what weight do you decide? Birth weight or?
So we always take the birth weight till the baby crosses the birth weight, and then we switch on to the current weight of the baby. We use a very high volume. 150 ml per kg is definitely what is needed, but we even go up to 200, 220 ml per kg to ensure that the baby gains weight well. And when you use 200 ml per kg or even more than that, you may not need to use human milk fortifier because the baby gets its whatever the baby needs from it. So we use the birth weight for calculation till it is crossed. Having said that, I was very impressed with one recent article which I read, which looked at what is the weight we should consider for SGA babies, because SGA babies, they are already very less as compared to their gestational age. And in that article, they talked about the 50th centile weight for SGA babies, and that helped them to increase the weight of the babies and overcome this big problem that all of us face on extrauterine growth restriction. But personally, I have not followed that yet, and it's still not a recommendation. But maybe, when we face that, we might have to consider some higher weight if the baby is very, very SGA. But that is only after we reach high amount of feeds, not in the initial period, because these SGA babies are also more prone for necrotizing enterocolitis. I hope I have answered that to some satisfaction, Dr. Tegine. Is that fine, or do you want any more discussion?
Thank you very much.
Yeah, thank you. So then maybe we can go to the next question by, I'm trying to see the full name. I can just read it as Dr. G.E. So can you please unmute and ask your question?
Okay, thank you. This is Gitaso from Ethiopia.
Hi, Gitaso. Yeah, please go ahead.
My question is, you know that the first line recommendation is human breast milk, but in case when there is no human breast milk, donor human milk is also as a second choice. So once it is stored and we take it out from the refrigerator, after how many hours shall we give this milk to the neonate? That was my question. Thank you.
Yeah. Marianne, you want to?
Yeah. In room temperature, if you are storing in room temperature, again up to 2 hours. But if you're keeping that in the refrigerator, then as per the recommendation that is given itself, you can keep up to 4 days.
24 hours.
20.
Yeah. We usually,
up to
if
4
we keep
days,
it in the lower segment,
24 hours,
it,
yeah.
up to 24 hours. But I don't know, Dr. Getiso, I hope I'm pronouncing it properly. You may be asking, like, after how long when we take out from the refrigerator, we can feed the baby? Was that your question?
No, I got it. Like after we take out it from the refrigerator, so we can give after 24 hours, as you said. That was my
No,
question.
once you take it out from the refrigerator, you should finish using it in 4 hours. You can't keep
Okay.
it for a longer time.
Long time.
If it remains in the refrigerator, you can use up to 24 hours. So if
So
suppose I have 100 ml of milk and it is in the fridge, I pour out only what I need, say 30 ml for the baby. That I bring it to room temperature and then feed. If I bring the entire 100 ml into room temperature, I should finish it within 4 hours. I can't use it longer than that.
So we can give it immediately after we take out from refrigerator, or shall we wait it until at least for 24 hours at room temperature?
No. You should
You
bring
should
it to
thaw
room
it.
temperature,
Room temperature.
which takes around, say, 10 minutes, 20 minutes. And what we recommend that you do is you take a container with just normal water and you put that refrigerated milk in that so that it comes to room temperature quite fast. And once it comes to room temperature, then you finish using it in the next 4 hours. Please don't
Okay.
keep it outside for 24 hours.
Okay, thank you.
Thank you, Dr. Geteso. And then we have Dr. Zafri, over to you.
Thank you so much, Dr. Salman. It was a very good explanation. I just have one question. After taking it out from refrigerator, is it possible, or what guideline is telling us that we can heat up or make it a bit warm for the child or not? What is recommended?
Not recommended.
Yeah, we don't heat it up. We don't put it on a stove and heat it up. We don't put it in a microwave and heat it up. The only thing that can be done is to put it in a bowl of water and bring it to normal temperature. But we don't heat up the milk at all.
Okay, thank you so much.
Thank you. Any further questions or any comments or sharing of experience, please?
Okay. Meanwhile, I lost a little bit of connection. I apologize. And if there are no more questions, I would like to show also the IEC. We have an IEC for parents. So maybe we can have some comments on that too.
Please go ahead.
Since we have a few minutes.
We still have another 7 minutes, so you can show the IEC and then we can wind up. You're sharing screen, Flavia?
I'll start sharing.
There's some questions in the chat as well, Suman. When to give breast milk in a ventilated newborn?
Okay. Sorry, I missed that.
You can answer, Suman, and then I will show it.
Yeah. Okay, there are many questions.
Many questions,
what macronutrient supplements are in addition to breast milk and the time to start the supplement? For preterm low birth weight babies, we definitely, when we are giving exclusive mother's milk, we need to supplement it with calcium and, more importantly, phosphorus. And we usually start supplementing it when the baby is around 100 ml per kg in enteral feeds. In addition, we give a multivitamin. Again, once the baby is under 100 ml per kg feeds. Babies also need a high dose of vitamin D. The Espegan recommendation is 800 units of vitamin D. So we need to also give that. These babies, we start iron at 2 weeks of age. And of course, only when the baby is on full feeds. So that is about the micronutrient supplementation. Then we go to the question of when to give breast milk in a ventilated newborn. We give it as soon as possible, Professor Mannan. Ventilation is not a contraindication to feeding. There are times when we have ventilated babies, very often when we keep them even on full feeds. The only contraindication to feeding is if baby is in shock and is on inotropic support. But otherwise, let us say a pure RDS on ventilation, these babies can even be on full feeds. And if there is any contraindication to feeding, we still ensure that they get colostrum in their mouth, which is an infection prevention tool. Yeah, not enough milk is a big issue for an ICU admitted babies. Many centers, the way forward for this is a human milk bank. And Professor Manan, you are in a position to ensure that you can set up such kind of milk banks in Bangladesh, not only in your leading institute, but throughout the country. In India, in the past decade, though we had a milk bank almost 35 years ago, in 1989 was the first milk bank in India. But in the past decade, numerous milk banks have come up, and it has made our lives so much easier for feeding breast milk to the preemie baby. So that would be the solution. But till then, intensive sound counseling, support, and ensuring that the mothers do KMC, come into the unit, express milk would be the answer. So I hope that that's adequate. Okay, then we have a question by Dr. Abdul Aman. LUCS is a hindering factor. I think you mean lower segment cesarean section is a hindering factor for early initiation of breast milk, as health workers are busy with the mother and family members, or sometimes does not get easy access to post-op room to take the baby to the mother. This is a very common barrier, but also, I must say, a barrier which we can overcome by policy changes and also by quality improvement programs, getting the nursing team in the OT on board, getting the obstetricians, and more importantly, the anesthetists on board. If they are on board and we can convince them, it is possible to not only do early initiation of breastfeeding on the OT table, but also do skin to skin contact for 1 hour, even for LSES mothers. So you'll need a strong policy change. And this is a very good area for quality improvement programs, and you can work on it. So I could share a paper that we did on early initiation, particularly in LSES mothers. Uh, Professor Manan talks about a very common problem, hypernatremia and exclusive breastfeeding. Very, very common. And now summer is coming up in our parts of the country, and we find this a big issue. The only preventive way is counseling, support, ensuring that the families are aware that breastfeeding is important, but it has to be monitored, constant weight check. And many of our units have a policy that as soon as there is more than 10% weight loss, we check the sodium of the baby to ensure that the baby is not going into hypernatremia, and we do intensive lactation support for such babies. So I see, oh my God, there are lots of questions. Savia, I don't think you'll have time for your IEC. They probably have to just look at it. For express breast milk, are there situations where spoon feeding is preferred to cup feeding alone? Uh, Dr. Sarah, I'm not sure. We have found cup feeding or palate feeding very useful. With the spoon, probably the only place I've found spoon feeding useful is in a babies who have a cleft palate, where we have a very long spoon and we put it when there is a cleft palate. But otherwise, we have found cup feeding as good because otherwise babies get only a very small amount in a spoon, maybe 5 ml, 3, 4 ml, and they get very irritated when they get the small amount, and therefore a cup holds much more, maybe like 10 ml, 15 ml, and therefore they prefer it. Do we have a standard for the temperature at which breast milk can be stored in a refrigerator? -20 is the freezer temperature, and +4 degrees is the temperature where we can keep it at for 24 degrees, for 24 hours. How do we get human milk fortifiers? Yes, it is a pharmacy item. It actually comes under, it's not an FDA approved one, but it is considered as GRAS, that is generally considered safe as food. It has to be either manufactured in your country or it has to be imported. So this is something that is a pharmacological item and you need to get it. I don't have any other answers on how to procure it. Even in our country, I think only around the end of the first decade of this century, we started getting it, and now it is very easily available. Breastfeeding inadequacy for higher order multiple gestation. Dr. Sadeka, For twins, it is definitely eminently possible to breastfeed, and we have had mothers who are twins. We have a milk bank now, and one of the biggest donors to the milk bank has been a mother with twins. So it's not a problem. But for more than that, triplets also, we have been able to sustain exclusive breastfeeding, I think, for around 3-4 months, and then they had to move on for support. But for twins, it is definitely a problem. It's a mindset. We should be clear that it is possible to exclusively breastfeed twin pregnancy, twin babies. Sorry, I ran through all the questions like a marathon. I hope it was okay with the mentors.
Thank you
If not,
so
we would
much.
still interact. Yeah. Back to you,
Mm.
Marianne.
Thank you. Flavia, do you want to share? I don't know with and run through it.
I can. We are just past time 1 minute.
Yeah.
We are just keeping track
Since
really
you just put
nicely.
it, okay.
Yeah, I can put it back again just quickly. So this is the IEC for parents on mothers on milk. So this is particularly important. Well, it's important for all moms that will have a preterm baby, but not only moms that will be in the preterm, in the SSNC, the preterm group that is in the SSNC, small babies that are sick in the SNC unit, but also for those moms that will have bigger babies that will be in the postnatal ward. So basically, this is something that we can give to them, and it can support the health workers that are even in the peripheral facilities to support the mothers when the baby go home. Give your baby the best start with mothers on milk. Begin feeding within 1 hour of birth. Keep your baby in skin to skin for 1 hour, and then if they cry at birth, it helps to start milk production and strengthens bonding. Why? Protects from infections, builds immunity, supports brain development, especially made for preterms or small babies. Feed directly from the breast or use an alternative method indicated by the hospital team for those who are committed. We will help you choose what works best for your baby. We will help with the first feeds and baby positioning. We can show how to express and store mother's own milk. Your milk is adapted to your baby's needs. Use clean bottles, utensils. Your milk will be stored 6 hours at room temperature or 24 hours in the refrigerator. So it's 4 to 6 hours, as we said. Don't give other milk, water, or fluids. Mother's own milk is all your baby needs for the first 6 months. Take a daily shower, wear clean clothes, always wash hands before touching the baby. Provide KMC 8 to 24 hours per day. It improves your milk production. Your milk is perfect for your baby. You're giving the best possible start. So of course, this cannot be just given to the moms. This is something that the staff is supposed to explain each topic when they give to them, but to give them support on how to start giving mothers on milk, either in the hospital, either outside of the hospital. Back to you, Marion. I think you're muted.
Sorry, yeah, sorry. Thank you, Flavia, so much. And thank you, Suman, for coordinating as well. If there are no more questions, we'll close the session, Suman.
Yeah, definitely. And
Yes.
maybe I think the next session is next week. Just as a reminder.
The reminder.
We have 3 more webinars to go, and I'm sure you all will make it as interactive as we have been doing now. Thank you very much.
Thank you. Thank you, Suman. Thank you, everyone. Bye.
Bye.
Thank you. Bye.
Thank you.
Thank you. Thank you. Bye.
Bye all. Bye.
Bye. Bye.